Hi, everyone. Welcome to the conference call today. And as Jan said, my name is Rhonda, and just a little bit of a background. I'm a registered nurse, and so I've worked in the clinical setting for 25 years and worked through a lot of these regulatory programs. And I know they can be very cumbersome, and they change the rules quite frequently. So we're going to try to look at the Medicaid meaningful use for 2018 today. Now, keep in mind that there are some rule changes that occurred last year with the Medicaid meaningful use. So what I'm looking at today is if you're going to be attesting using meaningful use stage 3. But I will mention a couple things throughout the slides here, some of the final ruling changes that, will allow you to do some different types of attestation for your Medicaid meaningful use. So as many of you know what meaningful use is, it's been around for several years. And, so meaningful use is really just the government's way of saying that you have a certified EHR and you're using it in a meaningful manner, capturing discrete data and being able to transmit that, and just keep track of quality measures and see how things are going with the patients. So history about meaningful use, it started around 2009, and there were several different stages. Stage 1 was just basically data capturing and sharing. Stage 2 was advanced clinical processes, and now we're moving into stage 3, which is looking at improved outcomes. Have, changed the stages throughout the years and allowed you to adopt the system fully so that, vendors could keep up and that type of thing. Medicaid did allow for a very good incentive to do the meaningful use promotion. So you were able to get throughout the years up to $63,000. Unfortunately, if you're a first-time attester at this point, there's no incentive payment. If you have attested in the past and this is a continuing attestation, then of course you want to go ahead and move forward with your attestations because you will still be receiving the payments based on that. But if you're a new attester, unfortunately, the incentive for that was the last year was 2015. So looking at moving forward, what are the goals for meaningful use? To support health information exchange and operability, to advance quality measurement and to maximize clinical effectiveness and efficiencies. So those are the goals that are set by utilizing the meaningful use program. Who is eligible? Physicians, nurse practitioners, nurse midwives, dentists, physician's assistants, and that's when they're furnishing services in FQHC or rural health clinics and that are led by a physician's assistant. All of the guidelines for meaningful use. I'm so sorry, everyone. I was told that my slides were stuck. I hope I'm caught up now. So let's see. So who is eligible for professional? Are we good, Jan? Okay. Sorry about that. I was using a secondary monitor. So Medicaid, you must have a minimum of 30% Medicaid patient volume. It's a lower percentage if you're pediatric, so it's 20%. Practice in predominantly FQHC or rural health clinics and have a minimum 30% patient volume attribute to the individuals. So those are the things that make you qualify to be able to attest to meaningful use for the Medicaid population. And again, what was great about being able to fall into that category versus doing the Medicare was there was higher incentive, financial incentive on the table for that. Hospitals, acute care hospitals, including CHS and cancer hospitals with at least 10% Medicaid patient volume, children's hospitals, and there is no Medicaid patient volume requirement for that one. At stage 3, so let's go back and talk a little bit about what was going to happen, and then with the final rule changes last year. So originally, the idea was that in 2018, regardless of whether you had just started in 2015, did stage 1 or wherever you were in the process, they were going to kick everybody up to stage 3. So initially, the requirement was going to be to do stage 3 for all Medicaid attestations. And also it was going to be a full year. So the final ruling came out, and the final ruling now says a few different things. So now you can do any continuous 90 days, January 1st to December 31st. So you do not have to report for a full year. You can just do the continuous 90 days. So that's one of the changes in the final ruling that came out. Also, that one of the changes that came out was instead of having to do just stage 3, they are going to allow you to stay on the modified stage 2. And in addition to that, the original ruling was that you would have to be on a 2015 certified edition for your EHR. That to change. So there's a couple things to look at for this. We do a modified stage 2 reporting, which is what everyone used last year. You can still be on 2014, 2015, or a combination of the two. If you're going to do stage 3, then you can be on 2015 or a combination of the two, 2015, 2014. However, if you do stage 3, you cannot be on just the 2014 edition. So if you only have 2014 certification, you would have to use modified stage 2. If you're going to attest to stage 3, you can be on 2015 or a combination if the mix technology does not prohibit you from meeting the stage 3 requirements. If something in that mix that your vendor has not met, then you would have to fall back and do the stage 2 modified requirements. Let's take a look at the measures for meaningful use stage 2. Now, I'm only going to look at the measures for meaningful use stage 3. The modified stage 2 would, still be the same. There's no changes in that. But there are some changes if you are looking to do stage 3. First thing that we're going to look at is, of course, is the PHI, and this has been consistent across the board every year that they've done meaningful use. And this is actually also rolled into the Medicare MIPS and MACRA program. So a security risk analysis is always going to be part of whatever regulatory program that you do. So if you're doing meaningful use for Medicaid, it's required. If you're doing MIPS for Medicare, it's required. So you would have had to have been doing this all along if you've been attesting. Again, you do have to have a security risk analysis performed within the calendar year of when you are going to attest to. So if you did meaningful use Medicaid attestation and your 90 days for 2017 were October, November, December, and you turn around in 2018, you did your security risk analysis in November of 2017, and then you turn around and use the first quarter for 2018, that security risk analysis is still good because it's a calendar year. But if you wait until the final quarter, then you would have to repeat that. So you just have to make sure that the security risk analysis has been performed within 12 months when your attestation reporting period is. Second measure objective 2 is the electronic prescriptions, and this measure has been around for quite some time. This was in the core group of meaningful use measures. So for stage 3, more than 60% of all permissible prescriptions have to be queried by a drug formulary and transmitted electronically. There is still an exemption for this, so any providers that write fewer than 100 permissible prescriptions during the reporting period or do not have a pharmacy within the organization that can accept electronic prescriptions within 10 miles, then you can claim an exemption. Keep in mind that that exemption, again, it's 100 prescriptions within a reporting period. So it's 90 days. So if your provider writes 500 prescriptions a year, but in the 90 days that you're going to report, they only wrote 70, then they could claim an exemption on that. The clinical decision support rules. So once again, you do have to do your clinical decision support rules, and these are, interventions that are based on, focused on improving performance on high priority health conditions. This measure in itself has 2 measures. So this one is to implement 5 clinical decision support interventions related to 4 or more CQMs that you select. So you want to make sure that that you're cross-referencing the CQMs that you've selected and make sure that you have a clinical decision supporting that kind of falls up underneath of that. So the example would be if you select a CQM for the BMI measurement and plan of care, and your system is capable of prompting the provider to say with a red label that says this patient's BMI is out of range, that could potentially be one of your clinical decision support rules because it does flag the provider that there is something that requires attention. So you have to do 5 of those, and you want to try to make sure that they're related to your provider's scope of practice, the type of population you have. So don't go out and if you're a care physician, you don't want to go out and select some clinical decision rule that would be related to ophthalmology or something like that. And then the second part of that measure is having functionality within your EHR that checks for drug and drug allergy interactions when you're working within the EHR. So you cannot use, originally in meaningful use, you could use like drug, and drug allergy as a clinical decision support rule. Now they have made that as one of the requirements of this particular measure. So you cannot incorporate that as one of your 5 clinical decision support rules. So you have to meet both of those 2 steps to qualify for that. And you can claim an exemption for measure 2 if your provider writes fewer than 100 medications during the EHR reporting period. Number 4 is your CPO, which is computerized provider order entry. And this one does have the additional sub-levels. So on this one, you have 3 separate measures that you have to incorporate. Is computer order entry for medication. This one is computer order entry for labs, and the third is computer order entry for diagnostics. So each of those, you do have to comply with 60%. So 60% of your orders do have to show that they were entered by the provider. Now, you can also have a credentialed medical assistant or medical staff member who can do this as well. You just have to make sure that they meet the guidelines of what CMS states is a credentialed member. Again, you have exclusions on this. So for medications, if they write fewer than 100, for labs, if it's fewer than 100, and for diagnostics, it's than 100. So if your provider is doing fewer than 100, they can do an exclusion on all of those measures. But it's based on each one. Measure 5 is your patient electronic access. And this as well does have 2 sub-measures. And within measure 1, you have additional sub-measures. So you do have to satisfy both measures in order to meet this objective. And it is providing the patient with timely electronic access to their health information. And then they have also, in the past, this has been sent out, patient education, but they have incorporated it into this message, into this measure, and that is patient education. So for the version of this is 80% of your patients having access to the patient portal within a timely center to allow them to view, online, download, and transmit their information. Also making sure that their information is available in the portal. Now, there is a new caveat to this as well, and that is that the patient has to have the voice that is configured to meet the technical specifications of what's an application programming interface. And so this one really ties in closely, so you can see that here. This ties in closely to your EHR certification. So if your EHR is not 2015 certified, this might be something that would prohibit you from doing the stage 3. Because this is such a new portion of the measures, a lot of the vendors do not have this in their combination 14-15 certification. So look closely at if you're thinking that you would like to do stage 3, but you're on the combination 2014, you do want to make sure that your vendor has the capability of doing this application programming interface, because if not, you would not be able to do the stage 3 attestation. And then the second measure is clinically relevant to the patient, is putting them with educational resources and provide electronic access to those materials in more than 35% of your patients. So you just want to make sure that your patient portal allows for access to patient-specific education materials. So this is a measure, again, that you want to look closely if you're thinking about doing MU3. Look closely at your certification and just make sure that you're capable of meeting this particular measure. Measure 6 is basically, it's kind of a new, it's a new measure. You would not have seen this coordination affair in stage 1, stage 2, or stage 2 modified. Typically what they have done with measure 6 is, as you can see, they've kind of taken, if you look at stage 2 modified, they are individual measures for what's called, I call it VDT, but it's view, download, and transmit your health information. That has in the past, it's been its own measure, and secure messaging in the past has been its own measure. So what they've done is they've taken and they've created a new measure, a new objective called coordination of care, and this is using your certified EHR to engage with patients or their representatives about their care. So again, you have 3 sub-measures within here. You do have to attest to all 3 measures, and at least on 2 of them, you have to meet the threshold. So if you don't meet the threshold on number 3, but you meet the threshold on 1 and 2, then you can still attest. You have to attest to all 3, but meet the threshold on 2. So the difference is measure 1 is 5% of your patients view, download, or transmit their health information or access their information through the use of the API. Now, API was what we discussed on the previous slides. So again, you want to make sure, but this is an OR. So because it's an OR, you could be okay if you are doing a combination EH certification. You just want to make sure that you look at this and verify that you can do both of these items. Measure 2 is 5% of your patients do a secure message. So that can be initiated by the practice or it can be initiated by the patient. And we found that one of the easy ways to really meet this one is at the end of the visit, make sure that you're sending their patient plan. Send them their patient education. So that way they're viewing it. Possibly do some bulk portal emails asking for return questions, that kind of thing. So if you're having difficulty getting the secure messaging, then you should try to come up with processes where you institute the message on your side. And this one is patient-generated health data or data from a non-clinical setting is incorporated for more than 5% of your patients. So again, it's just pulling in. So you could possibly have somebody that brings in a CCDA. You could include that, or kind of some examples that you might be able to do for that. On that, and Jan can provide me with your information, and I can possibly send out some examples. I can't think of some things right off the top of my head for the non-clinical setting, but we'll get you some examples on that. So probably with this particular measure, that might be the one that would be difficult to meet the threshold because it's new and trying to incorporate something, get a process into place for that. Next measure is the HIE, which is Health Information Exchange. This measure provides summary of care records for transfers and referrals. So this one also has 3 sub-measures within it. So 50%, I think, let's go, yeah, 50% of transitions of care that the provider transitions or refers the patient to another setting of care, creates a summary of care record using and electronically exchanges it. So making sure that when you do a referral that you're creating a CCD document and sending that through some type of health information exchange, such as in ECW it's called P2P, in NextGen it's called NextGen Share. The second sub-measure for this is 40% of transitions or referrals received and patient encounters in which the provider has never encountered the patient before, that the EP incorporates an electronic summary of care. So this is a new patient that you're bringing in. You want to ensure that 40% of those that you're reaching out to the provider that is referring it to you and saying, hey, can you send me a CCDA so I can electronically bring in the data. So some CCDAs have specific requirements, so they should be the same across the board. But when you bring that in, you should be able to upload the CCDA directly into your patient's records, such as past medical history, the problem list, the allergies, the medications, things of that nature. So bringing in a CCDA and electronically reconciling it with your chart. The last measure is 80%. And again, so these 2 things tie in together. So this is receiving it. This is doing it electronically with medications, allergies, and current problem lists. So there are 3 caveats to electronic reconciliation. Measure is measure 8. And again, measure 8 is something that has been around for, since the beginning of MU stage 1 with your immunization registry, and they just gradually increased it to additional registries. So you do have to show that you're active, that you have an active engagement with a public health agency or some type of clinical data registry to submit your electronic public health data. So one is your immunization registry. And of course, if you don't do immunizations, you can be excluded from that sub-measure. Measure 2 is the syndromic surveillance reporting. And that one, again, you can be excluded. That's a pretty tough one. There's not a lot of individual providers that would be reporting syndromic surveillance directly from their private clinics, but there are some that do. So, but if you're not in the category of providers that would be that type of information, then you can claim exemption on that. Or also, if in your area there is nowhere for you to report the data, you can claim exemption on that as well. 3 is electronic case reporting. And again, this is something that you can claim exemption on if you're not in the category of diagnosing or reporting reportable diseases. Measure 4 is public health registry reporting, and this one has really gained more momentum over the years, because in the beginning there weren't a lot of health agencies in your area that could do the clinician, but there are a lot of registries out there now, so you do want to go ahead and know that you have something like that. Now, if you can't, a lot of times they're not taking on new clients, because they only want specific, like maybe oncology or things like that they want to do reporting on. You can go ahead and apply to that registry and just show that that you've declared that you have applied and you're like a waiting list or something like that. So if you want to start looking into that, you do want to just make sure that that you got well in advance, because if you're going to attest and say, well, I'm eligible and I'm going to declare what's called declare readiness, you do show that you've done that like at least 6 months prior to your reporting period. So now's the time for you to really look at that and see if that's something that you need to do. And the last one is clinical data registry reporting. And this could be like, if you have a specialty registry like IRIS or Pinnacle, things like that. And again, if you don't, it's not too late. You can reach out to those registries. Sometimes it takes a while to get those things going. You just, again, have to show that you, process and that you're in the process, so when you attest, you can declare what's called readiness, but you have to do it 6 months in advance. So this measure is doable for sure. It just, it's not something that you can just flip a switch on. So you do want to make sure that you have plans and you have this moving along. Now, if you've been submitting, all along, you're probably well into these, so it's not going to be that big of an issue. So you can just keep doing the same registries that you've been involved in. So again, we kind of touched on the definition of the API. So this is patients are able to choose an application of their choice to access their record. Again, this would be the one thing, when we looked back at that one measure, this would be the one thing that you'd have to make sure a combination certification that you are able to accomplish in order to do stage 3. Patient-generated data needs to be included in 5% of patient records. We covered that. For new patients, a summary care record must now be sent and received and incorporated into the health record. That means you need to either request those from their previous PCP or go out to an information exchange and retrieve that. So these are some key things that we noted that changed within the measures. So those are just notable things that you would want to take note of. 3 concludes going over the measures for meaningful use stage 3. Again, if the filing says 90 days, you do have to be on a 2015 certified version. You can use a combination. Just make sure that if you're using a combination, that it does not inhibit any of the measures, especially those ones that I pointed out when we were doing the discussion. If you are comfortable with your stage 2 modified, you can continue with stage 2 modified, and you have some choices there for what certification, EHR certification version that you're on for that. So that concludes my presentation. This is my email address, so please feel free to take down my email address and send me any questions that you have. I will respond to you very quickly. And it was a pleasure, and I appreciate your time for this afternoon. Thank you so much.